So first of all, the first question I want to ask our panel came from the group, and I do forgive me if we've got some of these wrong, but I hope we've got them right. They came from the group 3 who were in the Compass room, and also from the South group. And it's how do we identify suitable patients for self-managed care? Dorothy, do you want to start off?
Can you hear me okay? Thank you. Well, first of all, obviously, it depends on the medical needs, whether or not there is ongoing treatments and the complexities of that. Clearly, it would be inappropriate to put somebody on self-managed who is expected to come up for treatments on a weekly basis. But then, very importantly, on the individual, that person's personality, character, and of course, based a lot on the outcome of the holistic needs assessment that usually the cancer nurse specialist will go through. So all of those things will determine who is suitable for self-managed care, and it should certainly be sort of tailored to the individual and the appropriate support given to that individual, depending on their own personal needs.
Mike, do you have a view on that?
So this straight away is one of the issues, isn't it? Because that sounds like quite a big thing to do. A follow-up appointment with me is 6 minutes. To do a holistic needs assessment, I don't know how long that takes. Perhaps, Jane, you would have something to tell us about how long this assessment period takes and how you would actually do that.
Tim, do you want to give your perspective?
Yeah, I think from a patient perspective, you would probably want to be referred on to some sort of roadmap sort of follow-up, which actually tells you your options for follow-up, whether you come to your clinic, whether you see your GP regularly, what's happening, how often, how frequently. And during that, I think there can be an assessment whether you are willing and capable of managing that yourself, taking ownership of that, or whether you still need a lot of support from the healthcare professionals.
Claire, do you...
I think just one point to add to that, and very similar to the previous point, is considering people's ability and confidence to manage some of the things that they may be expected to manage, whether that's consequences of treatment or making changes to their lifestyle and so on. Because if we're talking about an assessment at the end of treatment, we know that many people may be feeling quite vulnerable at that time, so we need to bear this in mind.
So is there anyone, perhaps, the lights have gone down a little bit, so I think I can see you. Is there anyone perhaps in the groups who raised this who wants to come back to the panel on any of these points? No, that's fine. Well, yes, sure.
I'd just like to add one thing about that. And in the pilot sites for the National Cancer Survivorship Initiative, there was the Ipsos Mori poll as a service evaluation done at year 1 and 3, and certainly by year 3 people were asked this question, how confident are you to self-manage, and 83% of that study said they did feel confident that they'd been given the tools and the support to do so. Thank you.
Okay. If you would like to say something about any of the points, do raise your hand while the other speakers are speaking so that we can keep things going. Yes, the holder of the football.
Hello, Dana Greenfield from Sheffield. The thing about the holistic needs assessment, there has been some work done. I know that in Bristol, a psychologist there has got the distress thermometer down to 17 minutes. That's a little bit optimistic, I think, generally. In our own centre, our breast CNSs take an hour to do that. I think that's probably a bit too long. It's probably somewhere in between. However, the main point is that holistic needs assessment is not necessarily the tool to determine whether or not somebody can self-manage. You can't imply that it is. It just means that they have needs at that particular time which could be easily met. So it doesn't necessarily mean that they can self-manage or not. And what we need is to look at their vulnerability. And it's not necessarily even the remit of the healthcare professionals, because there needs to be social care involvement as well.
Okay, thank you. Let's move on. I think we will come back to some of these issues and some of the other questions, but several of the groups group 1 that was in this room, the group 4 that was in the Compass room, and the group in the hexagon room all came up with a similar issue around vulnerable, what we can loosely call vulnerable groups. So how do you make, how will self-managed care work for vulnerable groups, and the sorts of groups that were mentioned were people with low literacy, mental health problems, learning disabilities, elderly people and so on, and how do we deal with assessment and support for that group? Claire, do you want to give a perspective on that?
I think there is a real concern that vulnerable groups such as older people who might be living with other conditions, people with low literacy or black and minority ethnic groups have been shown to be to maybe not have as much access to health, to certain support. So there's a risk that a move towards self-managed support may increase inequalities. So it's really important to consider having tailored support, specifically tailored for particular vulnerable groups that people may be working with.
Yep.
So I think the problem here is if there is a concept of transfer of responsibility, and that's where we're having the difficulty with the vulnerable patients and all of this. If we're transferring responsibility away from the specialist team to somebody else, and they don't have the capability of addressing that care requirement, then there is a failure of care. However, self-managed care does not have to include necessarily a transfer of responsibility. It can be an optional extra, and vulnerable groups may benefit from the meeting the needs, their unmet needs that are currently there, as much as the more vocal minority, at the same time as being properly supported by their specialist nurse, their oncologist, etc. So I see this as maybe quite key in terms of conceiving self-care as an alternative to traditional follow-up. But when we think of it as an adjunct to traditional follow-up, there doesn't seem to be a problem there. And then the benefits can be accrued by anybody, and it's not inequitable. And I think there is a problem about trying to offer services which are inequitable. That would be, unethical within the NHS framework to do that. So, but then it's difficult to see how we fund it. And I think that might be another part of this discussion, because at the moment, currently, the sort of funding analysis is based on a reduction in traditional follow-up in order to fund the additional resources that we need for self-managed care.
Tim, do you...
I think beside vulnerable groups in terms of ethnic minorities, etc., there are also people who are suffering late effects, who are mainly elderly. They're housebound often because of their side effects don't allow them to travel very easily, and they have lots of issues around that. And they feel isolated, vulnerable, and very, very much alone. So I think we, in the Pelvic Radiation Disease Association, we try to bring these people together and give them information. Now, they're self-managing at home because they are almost homebound, and they're using their relatives and friends to help support them, but they do feel very isolated, and I think we need to include those as well. It's not just a question of minorities who can't read English or et cetera, et cetera. There are patients suffering debilitating problems and just can't get out and about and get to clinics.
Okay. I mean, related to that point, some people were talking about, are there issues about collecting follow-up information regarding late effects, particularly in these sorts of groups of patients you're talking about? So you kind of led nicely into that. Are there issues, and how do we go about solving them if there are?
Yeah, a follow-up. I think there are a number of studies which are starting now, which are trying to follow patients for late effects. And I think there's a study on the Christie that's doing that. Now, the PRDA have, when people come to us to inquire about what our association do, we always send them a survey for them to fill in and give us feedback on their symptoms and how long they've had them, how severe they are, and how they're coping with them. And I think surveys are one way to do this, to survey patients every 3-4 5, 10 years, this sort of thing, to gather information on a large scale. Associations like ours, which are very small, can't do that on a huge basis. But we've already got about 150 surveys on our books at the moment. And I think that's one way to do it. I think there has to be a proactive follow-up, if I can use that term, in order to find out what the symptomology is out there and how people are suffering from these late effects.
Yes, we can take the point from the audience.
I'm Alison Walther, and I'm helping to run the pilot at the Christie on late effects. And I think what I was just becoming aware of really is these two things going along in tandem, which is the move of follow-up away out of the centres into the primary care as one issue, and then this whole other area of unmet need, of unspecified, unstated need amongst people who have late effects. So there are kind of two issues that we're having to address and have cost, huge resource implications.
Did you want to add something, Dorothy?
Well, it was just really to restate, state again something you've just said, really, that the self-management should be certainly supported and proactive. And certainly the evidence that came from the Health Foundation, and they did review, nearly 600 articles, and not just from the UK. And certainly that was actually quite loud and clear, that the proactive approach is really key. Thank you.
Thank you.
So just really, I just wonder whether we can make this a bit too complicated. So the Pelvic Radiation Disease Association, for example, identified 4 questions. And if the answer to those 4 questions is yes, you need to see a gastroenterologist. And if the people at the end of their treatment are given those 4 questions, and the GPs and the gastroenterologists know that if a patient answers yes to these 4 questions, they need a treatment, you can make a change now, even before you've introduced the electronics or the IT or the whatever. And it's within the national survey of quality of life of patients showed that if you answered yes to those 4 questions, it actually had a significant impact on EQ5D, possibly the most insensitive measure in the world. So I think we have enough knowledge to make small changes, and sometimes we try to wait for the big changes to happen. So I just wondered what the panel thought about that one.
Well, certainly that's one point in favour of doing the holistic needs assessment, obviously on the completion of primary treatment, when hopefully you can start to pick up any early effects and an opportunity to educate and discuss about things to look out for.
Yeah, just one point. The problem with this is, you're quite right, but many patients have late effects many years after their treatment is finished and have, by and large, been almost discharged from their cancer treatment centre. And it's those people you need to address. So you have 2 needs. You have the needs of the patient population we already have suffering from late effects from their radiotherapy or chemotherapy, and the future patients. And I think we need to put in, say, some sort of roadmap which they embark on in survivorship, which includes them and gives them all the information they need, like the little 4 points, etc., which they carry on through them year after year and keep sort of being reassessed in that way, so that future patients that's the norm for them, I think. So yes, little steps are important, but we also need more formal steps.
Thank you for that. There are, and in fact, where Jane is sitting, I can't quite see people putting their hands up. So please, if let the others know if you are wanting to say something and I'm not quite, and the lights aren't letting me see you properly. Before we leave this issue, though, of vulnerable groups, I'm just interested in whether the panel, or indeed anyone in the audience, has got experience of tailoring information or tailoring services to in a way that deals with a particular vulnerable group or several of them? Or is this something that really there still needs to be a lot of work done on? Now we're going to see this football being thrown across the room, hopefully. Yeah, it really does work, apparently.
Into the purple bit. Hi, my name's Tracy Burke and I'm an occupational therapist based in social services, working with individuals with palliative care needs. And we've talked about ways of helping vulnerable groups to have a voice. I just wondered, are we actually using the resources that are already out there available to us in community? For example, interpreter groups, carers groups are very strong in community and often are very expert at reaching out to people and understanding carers and clients' needs. Ethnic minority groups are often very isolated but also very powerful groups and very well able to support each other. And really it's just also, I thought, why are we trying to maybe decide what's best for patients? Are we asking them, as well as we could, what they think is best regarding self-management and what they actually need? Thank you.
Yep. Can we take the point in front as well?
Okay. Thank you. Andrew Makin, working with Adults with Learning Disability Partnership in Manchester. We produce a lot of material for vulnerable adults in easy read format, pictorial format, that details their visit to a hospital, details their visit to a particular consultant. And the Christie have worked very, very closely with us, and we've been able to get timed appointments for our clients so that they don't have to wait in the waiting room. They're at the hospital for 9:30 and they're seen at 9:30. And that works very well. The problem, I think, would be if you put them onto a self-directed pathway, that you would be reliant on the commitment and the abilities of their carers. And our carers, with the best will in the world, are often paid basic wage. They're often people who have English not as a first language, and they struggle themselves to get through the system. So how on earth would we expect them to act as a sort of second-party carer for the people that have got to have the follow-up?
So you're really advocating what Claire said earlier about a tailored approach, depending on people's circumstances.
Yes, absolutely.
And the person who spoke just before that led us very nicely into the next point, which several of the groups brought up, but it's a very, very topical issue in healthcare in general, and that's the whole issue of patient choice. So how relevant, and I'm going to ask each of the panel, how relevant is patient choice to all of this? And how can we indeed give patients a choice about self-management, and do we know what they want? Who would like to take that up first? We're all smiling. Tim.
As a patient and patient representative, I think Mark hit the nail on the head. A patient choice should begin at diagnosis. So they should be involved in their treatment and wherever possible given choices, even choices that they themselves may have found out through various routes and the internet and medical charities and that. And then from then on, again, they're empowered to make choices all the way along. So I think if they're capable of making choices and they want to make choices and these choices are deemed sensible, they should be allowed to do that.
Yes, carry on, Mike.
Okay, well, I'll have another go at a piece of political correctness here. So patient choice, there's a lot of talk about this, but the missing word there is informed patient choice. How can patients be expected to make choices about options which they do not fully understand? So that's the real issue. And, you know, I've had quite a lot of training as a doctor. It's taken a long time to get me to the point where I understand the differences between different options for patients, to try to convey that amount of information to a patient. And let's be honest about this, all of our patients are vulnerable. You know, there is no patient in the world who gets a cancer diagnosis who is not frightened to death. So, even if they are a PhD, and have better qualifications than me, that patient in clinic with me being asked to make choices about their treatment and how they're managed is vulnerable. So that is a real issue. And so patient choice, there is a lot of, I think, political correctness talked about it. Of course, we need to include our patients. We need to try to inform them. But, and this was one of the things that we discussed in our group, where does the responsibility lie? Is it possible for patients to self-manage themselves? Can they be made the expert, really? And are we not simply shirking our responsibility? Is this not sink or swim? You make the wrong choice. Well, it was your choice. You didn't come for your follow-up appointment. You didn't have your markers done. You relapsed. So that was your problem, not mine, because you're on self-managed care now. So I think patient choice is great. Informed patient choice is the key. In terms of doing tailored information, sitting in Manchester, a lot of our patients' literary skills is, really not up to a 4-page printed document. That is something that, particularly not in the situation that they find themselves in, they can easily assimilate and judge and make an informed choice about. So it's, I think, yes, patient choice, absolutely. But we have to be aware about the limitation of what we can do, cancer doesn't wait. It's time and tide, and cancer wait for no man. So you haven't got time maybe to spend a month thinking about what you're going to do.
Dorothy?
Yes, well, I'll agree with all of those points, even those made by my adversary here on my left. But patient choice very definitely is key and prevalent throughout the whole of the pathway, all the way from the outset, as Tim put so eloquently. But obviously patients need to know what they're choosing, don't they? And that's where the informed choice comes in, and that is obviously important, and that's all part of the support along the way, helping people to make those choices, and also to explain perhaps the consequences of those particular choices.
I would echo that and also say that it feels a little bit this morning as if supported self-management is an all or nothing option. So either you get all the support or you get no support, but actually it's self-management with support. And that support can include routine surveillance, for example. And therefore, in order to make an informed choice, it's really important to understand what it is that is available. And this may be highly variable across different hospitals and different services within those hospitals. So what does the self-management support look like? How do people get support if they want it? And do they feel able to get it as and when it's required? I think that all of those things are also important to make an informed choice.
Thank you. Yep, that's great.
Hi, I'm Julia King. I'm a Macmillan Development Manager. It's sort of 2 points, really. One was around patient choice, and I think we have to acknowledge people already have a choice and they exercise it. As a competent adult, I will make choices whether I have the information or not. The second issue is around supported self-management, and I think the point that you made earlier on about informed choice and where people get information from, that's what we have to do. People who are living with cancer or other long-term conditions self-manage every single day. They make choices that as professionals we may or may not agree with, but we have to respect those decisions and try and ensure that they have the information available to them to make the ones that we would suggest is the right choice for them. But ultimately, it is their choice, and I think we have to remember that.
When I underwent my radiotherapy, I met many, many patients who had not exactly self-referred themselves, but had sought to become referred to the hospital for radiotherapy from other areas where it was either not available to them, it was not offered to them as an option, and then they found out afterwards that it was a potential option, or that the facilities weren't there in terms of machine technology. So patient information is very important, and patient choice is very important, and those patients exercise both of those things.
Okay, well, thank you very much. Now, just moving very slightly, but the whole issues of choice and what patients want may be relevant. A couple of you talked at least a couple of the groups talked at some length, I think, about the interface between primary and specialist care. And I think I'm the only primary care person on the programme. And so I was quite interested in the debate I heard earlier that I didn't hear very much about primary care. And somebody in the I think it's the South Room group, I'm sorry if I can now have the problem, of course, trying to read my own writing. They very specifically didn't just want to know about the interface between primary and specialist care, but they also wanted to specifically know if Mike thought that GPs were neglecting cancer patients. So I think I should ask Mike to respond to that point, and then ask the other members of the panel what they think about the primary specialist care interface.
I have enormous respect for the GPs who have a terribly difficult task compared to mine. I am a specialist who is presented with patients with a known diagnosis. I am supported by one of the best hospitals in the world to provide that patient with the best oncology care. The GP's situation is completely different. You know, they are the goalie with people shooting at them from every angle. So the GP's job is extremely difficult. And here we sit as oncologists saying, you know, okay, we're going to be discharging patients for more care in the primary sector. But then so presumably are the neurologists, the rheumatologists, the cardiologists, the mental care people, and everybody else who is sending those GPs protocols for shared care and ways to interact with their services, not just from one hospital, but from dozens of hospitals. And we are simply a part of their daily life. So it's not neglect. I think it's extremely difficult. And, you know, one of the thoughts that come to me is, you know, you don't buy a dog and then bark yourself. You know, the country has spent millions of pounds training specialist oncologists. Why shouldn't they be the ones managing patients with cancer? Why are we suddenly expecting GPs to get involved in an area that they are not necessarily familiar with and is simply one of 20 different types of medicine that they need to help with their patients? So yes, the GP role is very important, and I'm very interested in, you know, hearing about the model about how that works. But I see the responsibility, I keep coming back to that, don't I, about patients' care for patients with cancer should be with cancer specialists.
I'm going to ask Dorothy to speak next, but before I do that, I'm going to take Chair's privilege to respond to that myself and say that I think what that argument misses is the fact that GPs are actually seeing these patients. I spent many years speaking to breast surgeons about work I did in the 90s, and the biggest surprise to them was that in the first year after breast cancer treatment, on average, women with breast cancer see their GP 10 or 12 times, and they see them about 7 or 8 times in year 2. So these people have a relationship with the GP, and they are being seen. And more recent work has confirmed that. Dorothy.
Well, I would say in an ageing world, or where patients and survivors are ageing, many people have a lot of other comorbidities. They've got blood pressure problems and arthritis, some depression, and actually it's their GP that will know an awful lot more about that than their specialist. And we're talking about holistic care. So in fact, I would go so far as to say the success or failure of survivorship depends on that primary secondary care interface working really well. And we have to have dialogue, and we have to collaborate. And I think that's a really, really important piece of work.
Claire, do you have anything you'd like to say?
I was just going to add that some of the support in primary care may be also important in relation to lifestyle and supporting lifestyle type changes. That was the only.
Tim, do you want?
I have great support from my GP, but they, like a lot of practices, they have multiple GPs and they have trainee GPs who come in and out. And I think the key to the GP story is to stick to one GP, regardless of who else is in the practice, so that you build up trust and you build up a repertoire with the GP about your symptoms, because obviously somebody coming in new isn't going to read through all your notes. And like you say, you will have comorbid conditions which may or may not be impacted. And I think that is very, very key. My GP was quite surprised when I went with my pelvic radiation symptoms and I showed him the sheet of possible side effects from the hospital, and he said, "Oh my God, I didn't realise you could have that. I'd better bring my dad up. He's had pelvic radiotherapy." So they're not totally informed, because often they don't have that many patients to see. But once you lock onto them and inform them, and you have the letters referred from the consultant specialists, they do get on board and they can be very, very helpful and supportive.
Thank you. Yes, point from over there. Yeah.
As an ex-GP and now working as a Macmillan GP in West Norfolk, one of the important things is that it's very difficult now with large practices for people to be seeing necessarily the same doctor each time. They may have a new symptom that might be related, it might not be related, and they're very keen to get that thing sorted out quite quickly. And if you can't get an appointment for 10 days to 2 weeks to actually see your specific GP, then the system has failed. But on the other hand, the other thing that's happening, of course, is that GPs do have an obligation to actually look at a cancer care review on a regular basis and have GSF regular meetings. So in fact there should be a focus fairly frequently for GPs to be actually looking at patients who've got who have cancer. So I think that's quite an important point. That there is the follow-up is should be there and is there, but there is still an enormous variation in knowledge across general practice of different cancers and what they're there.
So do the people who were in room 6 think that Mike answered their question? Yeah. Yes. Don't know whether you were in room 6.
This way.
Are you on the purple side?
Purple side, right. Afternoon. My name is Sudip Badori. I've just turned 55 this week, and I've actually semi-retired, so it's quite a great week for me. I'm a Mancunian, and I'm very proud of it. I actually work in North East Lincolnshire. I'm a lead GP in cancer and palliative care in Cleethorpes. I'm pretty proud of working there too. I'm the guy who wrote that question down because I don't think it's a dereliction of duty at all. I think it depends on the locality you work at. We have regular MDT meetings. We have a very robust System 1 computer system where we can actually pick up cancer care reviews. I have to say my waiting list for a routine appointment is now going to be more than 7 days because I've gone part-time, but that's not my problem anymore. With regards to what's going on in our locality, there are lots of GPs who do pick up patients who've been discharged from hospital care. 9 times out of 10, they're patients like, prostate cancer patients, breast care patients who clearly, they go every 6 months to a year, but they're absolutely fine. So the responsibility lies with us. So it'll be a dereliction of our duty if we don't share the road with the patients who have been empowered with their responsibilities. I think it works very well for us, and it will carry on. I've left a legacy for the next few years. So I think you'll probably find, Mike, there are GPs out in the UK who actually do a pretty good job. Thank you.
Would you? I'll let you come back to that in a minute. Let's take the point down here first.
Karen Holmes from the Cancer Support Centre in Sheffield. I think if we're going to let patients self-manage and we're going to empower them with information, they should be able to go to the GPs, armoured with being kind of the expert patient. So like you say, you've gone along with your list of this is what you need to look out for. That's ammunition to sit there in front of the GP as well, to update them if they're not already up to date. In Sheffield, we're doing a lot of work with the GPs, so they have got that resource already.
Mike, do you want to come back? No?
It's not so much a question, it's more of just something to raise. My name's Ali, I work for an information and support service in Manchester, so working with people affected by cancer out in the community. there's been a lot of talk about this morning about sort of the medical side of things, but often with people who've had cancer can be affected in all kinds of ways, and it might be that they need sort of, you know, benefits, help with housing, support in building up confidence to go back to work, all those kind of issues. So I would really like to advocate the role of the information and support services. You know, we can pick up these kind of issues, and then that leaves the clinical staff to deal with those issues. But I think it's where those unmet needs get picked up, and I think with the holistic needs assessment, it doesn't necessarily need to be a clinical member of staff who does that. You know, information and support services can, and then sort of, like I say, direct people where they need to go.
Let's move on. I'm aware of time and we're marching towards lunch, but let's just move on very slightly to ask something which I think clinicians in particular find very challenging. But let's see how the panel manage it. I think one of the groups in this room was interested about the whole kind of more macro level of things. So how on earth do we organise and resource services to support sustainable self-management? Because I think, as one of the speakers, if not both of them during the debate, talked about, there's not a bottomless pit of resource from which all these things can be done. Dorothy, what do you think?
Well, we're having a really easy time in the NHS at the moment with organisation, aren't we? So we've chosen a good time to introduce any sort of change. The landscape out there is difficult, and it's silly to deny that. But we always like a challenge, don't we, in the NHS? I certainly think that the key is that the survivorship pathway needs to be commissioned by our commissioners. And it is getting to the point of accepting and embedding that into the organisation that's going to be really important. As we said, in fact, both of us in our different ways, there is no money, there's no extra money. And so what we have to make sure is that we use that money smarter. And I think that the new models of aftercare are actually going to do that and bring an improvement to our patients, providing, of course, it is done appropriately and tailored to the individual patient's needs, and of course the all-important supported.
I completely agree with that. And in terms of breaking the mould, I think maybe this is, you know, where the lever really needs to be applied, because the shape of our current follow-up services is largely determined by the tariff structure and funding arrangements that are in place. Having said that, of course, those funding arrangements were based on the services that were there in the first place. So it's a sort of circular argument. But if we want to change how we do aftercare for patients with cancer, we need to break that mould. And I think that's a very interesting concept. And I don't certainly understand fully the implications of unbundling tariff and how that is going to change funding in the health service, and whether sole providers will be able to, commissioners will be able to commission sole providers for the entire pathway. All of that is, you know, a part of the story that we're being told, but I've yet to see it in practice. So that is obviously a way to break the mould, is to change the way that things are funded.
Within the NHS and within the charities, there's a commonality of need for looking at survivorship issues, and there's a commonality of purpose. What's needed now is a common practice that they can all subscribe to and cooperate and coordinate, so that the funding can be directed into a more streamlined system, which goes from diagnosis treatment onward throughout a patient's life as they journey along this road from diagnosis to hopefully long survival.
And just one further thing to add to that, I think there are a number of pilots that are happening across the country in terms of trying different models and testing different models of aftercare in supported self-management. So the gathering of evidence is going to be really important for persuading and making change.
There's usually lots of views on resourcing of services. And yes, please carry on.
There's been a lot of talk about liaison with the patient themselves. One of the things that concerns me, I'm a nurse by background and a governor of the Christie's Trust, but one of the things that concerns me is the importance of educating the general public. We did talk in our group a little bit about health and wellbeing boards, and I'm just wondering how we prepare the public, not the patient who's in front of a GP today, for the change in the traditional way that we do things. And there seems to be a massive task to do there to prepare the culture for the changes in the NHS, which will benefit the patients ultimately.
I mean, this relates quite closely to another question, which was maybe being discussed about at the same time, which is, and it's actually, we're getting onto something that's bigger than just for cancer survivorship, but it's about how you enable cultural shifts. You know, so what if we're talking about wanting to see some degree, and the debate is about how much that degree is of cultural shift in the way that people are looked after, how do you enable that? Any of the panel want to pick that one up? Or you shift things by carrots and sticks, don't you? So is it a carrot or stick approach? Or how, and I suppose linked to that, people were also talking, I think, in some of the groups about best practice. And again, that doesn't relate to in other topic areas and disease areas. You hear about the same thing, and you come across, and there's examples in the posters today. There's of best practice, and how, you know, I don't think the NHS is terribly good at managing to roll out best practice and how you do that. And are there ways in which we can stop all reinventing wheels? Yeah, Wendy.
Could I say, I think I was with one of the groups that generated that question, and it arose from a discussion around how do you identify patients who can be empowered to self-manage, and then we got on to saying, well, there's a real cultural problem here, because we tend to be passive when it comes to illness, and it's something that's happening to us, treatment's being done to us, and this is quite a shift in thinking, and we recognise that perhaps for older people, they may still expect to have more directed care, perhaps increasingly younger people coming through may have different approaches and expectations. But our conclusion came that it actually started much, much earlier on, before any illness and diagnosis, that this was something that needs to be embedded in public health education. So as well as sending lots of healthy lifestyle messages, we could be doing more about changing people's views around illness and health.
Any thoughts on how that's challenging, isn't it? Any thoughts on how we could go about that?
Yeah, I think if you're going to have a cultural change like that, I mean, it's very much down to colleges and schools from that point onwards. We now encourage schools now to teach young people how to manage money, how to manage their diet, how to manage their exercise. There's no reason why you shouldn't also teach them how to manage their health issues and what resources they need to go to and how to use those effectively, you know. And I think that's probably where you want to start, and then perhaps 2 generations later, you might get somewhere with a cultural change.
Yep. Oh, sorry. Yes, that's fine. Yep. It works.
Hi, I'm Penny and I work in palliative care. And just talking about culture, I think we need to remember there's 2 sides of that continuum, and that actually we already have people that are keen, like the gentleman that spoke to us this morning, that are wanting to self-manage already. So, you know, going forwards, we have to remember that. It's not just changing people that are in the service now, it's making it right for the people coming through.
Yes, I obviously wasn't in the discussion about a culture. I think probably the emphasis was more on the service rather than on patients. Is that right?
Yes, I'm sure it is.
I mean, there's 2 different aspects.
But you've got to remember there's an expectation from people that will want to go out and find their own information and do some of their own things anyway. So part of what we need to do is think of the future.
And support that, yep. So if you could pass that forward. Yep, come back while the football's been passed.
Sorry. I think this is this is the really nub of the whole issue from my point of view. It's the Western sort of love of technology and our cancer centres, our huge cancer centres. And for my part, this is very, on a personal basis, if I was to be diagnosed tomorrow, I would want to be in one of the biggest and the most shiniest, technologically strong cancer centres with all the medical people around me. But that is the difficulty, that at the other side of things, if we really are trying to talk about the paternalistic medical approach to things, then how can we truly bring up children who feel they have the power to provide their own support within their own family situations and their own systems and structures? So the culture is quite different to that. We're growing up in a Western world and sort of the inevitability of the need for technology. I'm not sure how we're going to solve the problem there.
Mike, you were waiting to come in.
Yeah, so I would like to echo what Jane was saying, and in fact something that Dorothy was telling me yesterday about how to change people, is to start small. And I think that small changes, showing benefits, is the way that you create cultural change, because then you create trust, if I've got Dorothy's steps right, and then that will encourage people to adopt the same kinds of behaviour. So I think what is alarming for some of the services is to see large reports suggesting widespread change without very much testing or having been thought through, the unintended results of those kind of changes, whereas small change is much less threatening, and if it is successful, it breeds further change. So I would definitely like to support the idea of small changes rather than a big top-down approach to this.
Yeah, that's kind of echoes what Jane was saying earlier about questions. Other thoughts on this topic of how, not only of how we get change, but how we also roll out best practice?
Hi, can I just suggest that maybe one quick small change is that we stop calling them our patients? Going back to what Mike said, he was a person, and maybe one small change is to stop alluding to them as our patients. They're not ours, they're individual people in their own right.
Other ideas of small changes? Because there does seem to be general sort of, there doesn't seem to be any disagreement to the idea that making small changes is a good idea. Does somebody else pick up the, yes?
I was sort of just thinking about commissioning, funding and everything, and knowing how big the survivorship agenda is. And for my own sort of interest within the room, how many colleagues are here from commissioning today?
A few.
Yeah, that's great, actually. I didn't think it was going to be that many hands, so that's a really good result. Thank you.
Can I ask a small change and say, could we abolish the word discharge?
I won't ask you in which meaning of that term you're referring to. that may be the inherent problem with it. Now that we're coming to the end, people are determined to get this ball thrown around the room, which is great.
I'm just thinking about talking about change with one of my several different hats on that I've had on. It's looking at lifestyle changes in one of the roles that I do at the moment, and actually one of the biggest changes that's kind of come up in my job this week was the fact that we used to all talk about 5 fruit and vegetables a day, and now everybody's talking about about the 2 and 5 or the 7 or whatever everybody wants to look about. But actually when you go to some of the communities that we visit, they don't even eat 5. So you've got to have a small change in one community is actually a massive change in some others. So sometimes you have to do different things for different areas and hoping that it's all going to end up at the same place eventually.
Hi, my name's Bridget Wright. I'm from the University of Cumbria. I just wanted to make a suggestion about a small change. It's not rocket science, but what about collaboration in your small change? Recently I've been involved in a breast cancer recovery programme, and the women were referred by a consultant for a 12-week programme. And the key thing is that they were actually co-designers of the programme that they wanted and needed. And it's really a case of, a bit like one of my colleagues said before, it's what the actual cancer patient requires, not what we think they require. And that when somebody has more autonomy in what they need, we're providing with the strategies and techniques to enable them as best they can to care for themselves. And obviously this self-management group doesn't work for everybody, but for certain people it was particularly successful.
Yeah. Could you just pass that behind you to the gentleman? Yep.
Just with commissioning being brought up, I just want to kind of highlight the fact that I think, as a commissioner, I think the influence in commissioning is vital to all this, because you can talk about self-management, but if the services aren't out there in the community for patients who are being told they need to self-manage, then things are going to fall through the cracks and people aren't going to get the service that they need. And from working within a CCG and working with other CCGs, there's a very, very vast difference in the focus on cancer within different CCGs, and whether survivorship or living with and beyond cancer is even a vague focus in some of the CCGs, and some of them are even thinking about this. And there are, Macmillan are doing putting a real focus on influence and commissioning, and I think that's going to become more and more important.
Yeah, thank you. Now, was there somebody? Yep.
Hello, my name's Julie. I work with an organisation called Working Towards Wellbeing, and I'm a health psychologist by background, which is quite unusual to be in this kind of environment. But thinking about behaviour change and small behaviour change, well, I think one of the most effective things you can do is actually work with what's important to the individual and what they value. So if you're going to start with a small change, then I think healthcare professionals have to work in a very collaborative way, exploring the individual's perceptions about behaviour change, about what self-management means, and actually starting with something small is what's really important to them. And if you start there, you're going to get into the patient's mindset to be able to move them forward. So I think about values and what's important to the individual is all about small change.
Well, thank you very much. I think that's a very suitable thought, actually, on which to end this. I'm going to... the organising committee have ad hoc listened to the will of this audience, and we are going to take a vote, maybe a rather we'll need to just judge the show of hands. We are going to take a vote on the outcome of the debate. Before that, I have warned them, so this is not completely off the cuff. I'm going to ask Dorothy and Mike both to not spend no longer than 60 seconds on summarising their key points so you can remember them, and then we will take a vote. I hope that, can we change the light, as Mike and Dorothy are doing that, can we change the light so that we can see the audience better, so that we can have some view of who wins. Dorothy, you spoke first in the debate. You go first.
Well, I'm not going to go through all of that again. It would take longer than 60 seconds, really. But I just want to say it is what it's not about. It's not about abandonment. It's not about abandoning the patient completely, not about abandoning to our primary care colleagues. It's about enhancing those areas that actually there's a lot of self-management going on out there anyway. It's enhancing and supporting that. And regards first steps, I would encourage teams to try and find a way of instigating the health and well-being programs, the moving on days, because the amount of fantastic positive feedback that you'll get from patients will be enough to sustain and drive the program through. Thank you.
Okay, so I guess what my points were is that you don't buy a dog and bark yourself. The emperor is nude. And I think we have to be aware that managed self-care and patient empowerment are good, but that doesn't mean to say that it should replace traditional follow-up as well. And the responsibility for oncology care needs to remain with the oncology specialists.
Well, thank you both. So if I could remind you all of the proposal, of the motion, and we'll ask for a show of hands of those who agree with this motion first of all. So proposals for self-managed follow-up are a dereliction of NHS responsibility to patients with cancer. So those in favour of the motion, raise their hands. Okay. Those not in favour of the motion, raise their hands. I don't think we need better lighting to actually work out that the motion was not carried by this House. Thank you very much for being such a phenomenal audience, and thank you very much to our panel. I think Wendy probably has something to say before we finish.